Dr. Freddie Rayray is a critical care pharmacist and a native of Stockton, California. He was actually introduced to me by one of our own staff members and one of his longtime friends, Elaine Labson. And so Freddie received his Bachelor of Science in Biochemistry and Molecular Biology from UC Davis, the Doctorate of Pharmacy from UOP, and is a board certified pharmacotherapy specialist. That's fun to say. Freddie's clinical experience includes direct patient care within the neurocritical care, trauma, medical, surgical, pediatric, and COVID intensive care units. So he's worked pretty much in all of the big time areas in the hospital. In an effort to combat misinformation and to make healthcare information easier to understand, Freddie started a YouTube channel and an Instagram page to educate others, and you can follow him at TraumasistRx. And I think I will look up the YouTube channel and put it in the chat so that you all can subscribe to his channel, because it'll be a great resource over time. Just like that QR code, if you subscribe, you can keep getting updated information from Freddie. So without further ado, thank you so much, Freddie, and I will hand it off to you to talk a little bit about yourself and address some of the questions that we've presented to you. And then afterwards, if anyone else has any remaining questions, they can feel free to ask those.
All right, well, thank you guys for the opportunity. I know there's a lot more things we could be doing with our time, but thank you for listening in on the conversation. I know that at the beginning of our presentation, Amy mentioned that cases are kind of downtrending, but if you look at the bigger picture, cases are really double or 3 times the amount of cases we've had since last year, just because Delta is still so spreadable and contagious. So there's a lot of new information, and before I get into a lot of your questions, I do want to share what I see on a day-to-day basis. So as Amy mentioned, I'm a critical care pharmacist, and I work in a lot of different ICU units to help the nurses and physicians. And one of my main roles is really looking at the medications, working up the patients and making recommendations, and also helping physicians take care of the patients. And a lot of what I've seen so far in all the ICUs, especially this summer, is a trend in a lot of younger patients in the ICU, mainly. So for the adult ICU, I see a lot of 30 to 60-year-olds. And actually, over the last couple of weeks, I've seen quite a few 24 and 28-year-olds. So I'm 28, so pretty much my age patients coming to the ICU. And just to give you a little bit of a picture of what that looks like, so you might have heard of patients in the ICU being ventilated. And a lot of the time, they can't breathe on their own, so we have to put them on an oxygen mask. And because they can't breathe on their own, usually they'll have to be on either a CPAP or BiPAP mask, which is a mask that helps inflate the lungs and gives positive pressure to allow their lungs to absorb oxygen. Or if they can't tolerate that or are still requiring a lot of oxygen, we'll intubate a lot of patients, and they're heavily sedated and monitored 24/7. And kind of just to paint the picture a little bit more, a lot of the patients we see on oxygen masks, once you take off the oxygen mask for a few minutes, their saturation goes from 100% oxygen all the way down to, the 70s, and so fast that they can't even eat their own meals. So a lot of the patients I see can't even eat while they're in the hospital, and they have to get their nutrition through an IV. And that's how severe COVID is as far as the Delta variant and what I actually see for the adult side. A lot of younger patients nowadays, and it's a little bit scary to see parents with young children fighting for their lives in the ICU, and also seeing a variety of patients who are not just anti-vaxxers, but those who back in May and June didn't really think COVID was a thing anymore because we were all opening up, and we're too late to get the vaccine. And right when they come to the hospital, they're saying, I was about to get it a couple of days ago, but I kind of lagged, and now they're infected. And also a lot of people who can't get the vaccine because they're allergic to something. So I'm seeing quite a different variety of people, but mainly it's people who didn't really get educated on the vaccine very well. As far as pediatrics, the youngest patient I've seen has a positive COVID result was a 7-day-old, and that was really because their parents were both unvaccinated and probably gave it to the child like right after, or the baby right after they were born. I've also seen pediatric patients who have immunocompromising diseases such as cystic fibrosis, age 12 to 13 to 15, and their parents also weren't vaccinated and ended up in our pediatric units because they needed more treatment for their cystic fibrosis and also COVID, which made it worse. And I've also seen the casual, age 12 to 18-year-old who got exposed through school because somebody's parent wasn't vaccinated, and then their children were exposed and then spread it at school or at extracurricular activity, and those kids were also healthy. So seeing a wide range of patients from 7-day-olds all the way to 30 and 60-year-olds is kind of what we're seeing in the ICU nowadays. And it's a lot younger and a lot scarier because all of these people shouldn't really be in our ICU. And one more thing about seeing all these patients is a lot of these patients are in our ICU for a very long time. So it's a very, I would say that a lot of these patients are in the hospital for three weeks or more. And it's very hard for them because they're always on a daily basis gasping for air. And it does a lot of damage to the lungs. So in general, that's the population that I see in the ICU. And based on the therapies that we have, we try our best to, do the steroids, do the ventilation, do the lung exercises, monitoring all our patients so they're not overly sedated, and trying to get them rehabilitated and to fight COVID on their own end. Yeah. Oh, one more thing. A lot of my adult patients, actually all of my patients in general that are COVID positive, 98% of them are unvaccinated, and I've only seen like a handful of patients who are fully vaccinated, and those were those who were elderly, age 65 or older, and would qualify for a booster. So that's also another population that we're seeing. So if you do ever want to talk about, I guess with canvassing, people who might be younger and hesitant to get the vaccine, nowadays in the ICU, it's not so much the elderly people. We might see a 70-year-old or 80-year-old there once in a blue moon, but it's really the younger people, the people who are young parents, the people who went to a club or rave or something and got exposed at a party and were unvaccinated coming to the ICU. And again, these are long ICU stays, and it just takes up room for patients who need it. And then one more thing actually that happened this week, I had a patient who got a stroke. They were 50 or 40 years old, and they had a stroke because of COVID, but because our COVID unit was full, they were in the ED emergency department waiting for a bed. So we have a lot of situations like that where because our COVID patients are really sick and young and unvaccinated, they're taking up a lot of beds and resources where we can't really treat everybody that we need to treat. And so that's kind of the population that I'm seeing right now. And that doesn't include all of our other sick patients. So the hospital I work at is a level 2 trauma center. So we see pretty much everything from falls, accidents, other traumas, and things like that. And we can't really treat those patients to the best of our ability sometimes because we have a lot of resources moved to our COVID patients. So that's kind of what we're seeing right now in the population. And that's why I think that what you guys are doing with vaccines is really good. We are currently, I believe in San Joaquin, maybe 50%, and Amy can double check me. I think it's 50% fully vaccinated and maybe 60% have at least one dose. And what we've been talking about in the science community and the healthcare community is getting as many people, getting most people fully vaccinated, at least 80 to 90%, because of the Delta variant would be ideal. And the best way to get us past the pandemic status and into something more like the common cold, where we just maybe see the flu every winter.
I have a quick question. So
yeah.
One of the things that I hear often is like, COVID is not that bad. It's basically like the flu, and I deal with that every year, and it's not a big deal. And I think I have a picture in my mind of what it looks like for someone to be hospitalized with COVID. And I know you were just sharing some information about, being being on a CPAP machine, potentially some people having to eat through feeding tubes. You were talking about steroids in your lungs or damage to the lungs because people have been there on those machines for so long. Are there other kind of pieces of that you can share that will help us have a fuller picture of what it actually looks like for someone to go through that and get hospitalized?
So the scary thing about COVID is it affects every organ system in the body. So a lot of people associate COVID with the lungs because it's a respiratory disease, but really what COVID does in essence is hijack your entire body, and a lot of the proteins that COVID produces, not including the spike protein, but everything else that COVID produces, can cause clotting. So for instance, I had a 24-year-old patient who they tested positive for COVID, spent 10 days at home trying to get better. And because they were not really moving around, they ended up having a blood clot in their lungs, which we call a PE, pulmonary embolism. And they had to go to the hospital 12 days after they tested positive to try and take anticoagulants to clear that blood clot. So a lot of the patients who have COVID are at higher risk of blood clotting. They have shortness of breath, which we've been talking about a lot. And a lot of that time, patients are really delaying their care because they think it will get better at home. But really patients are just gasping for air to the point where they can't eat. They can't really do anything because they're so tired from gasping for air. That's a lot of things we see. We also see the neurological things. So with the increased risk of getting clots, people can have strokes. And we've seen that in a lot of younger patients, specifically 35, 40, and even 50-year-olds, which isn't normal. And these are all people who are healthy, by the way, without any comorbidities or other medications at home. We're also seeing, from the neurological standpoint, people having confusion, fatigue, having brain fog, which is something that's really affected people's ability to be productive at work. One thing I've also seen is with the taste and smell, usually people have that for a prolonged period of time. So it can be anywhere from 7 days to 14 days. But if your job depends on your taste and smell, like being a baker, being a chef, working at a restaurant or anything like that, sometimes your taste and smell might not come back for months. So I've heard stories about that where COVID affects people who might not have severe symptoms, but cannot get their taste or smell back within months. And also when they do get their taste and smell back, it's not the same. So one specific story is there was a baker she has a whole bakery in Napa, and she got COVID. And incidentally, what happened was her taste and smell was lost at the beginning, like everybody else would typically have, but it didn't come back for months. So she couldn't even taste her own cooking, her own baking. And as a baker, that's your livelihood impacted by COVID. So we're seeing anywhere from those mild symptoms to more severe symptoms, neurological wise. Yeah, so COVID does affect all the organ systems. It's not just respiratory. It's every organ that you can think of, even, liver, kidney, all those things. I would also say that the impact goes much further. So you have, if someone is positive with COVID, and they're not vaccinated, they're much easier at spreading COVID-19. So they'll spread it to their families. And a lot of the families in Stockton, we know, are multi-generational. So that's something that maybe you can bring up to the people that you talk to. If you live with, someone mentioned they have a kid who's going to school and they were worried about getting the vaccine and that causing someone to get sick. Well, the actual honest truth is that because they didn't get the vaccine, they might bring home COVID from work to their family. And then you have that person's parents getting infected and also their kids getting infected. And if they're going to school, maybe they might be a spreader of COVID-19. So there's a lot of different impacts and a lot of different ways that COVID presents itself. And then you have to think about it from the point of view of someone who's a working parent. If they have COVID, they can't go to work for many days, and that's a loss of income for most people who might not be living in the best situation. And also from a hospitalization point of view, it costs a lot to hospitalize a COVID patient. What I've seen is for the ICU patients specifically about 30,000 to 70,000 per stay, and that's anywhere from a few days to many weeks. And it just depends on that. So there's the financial aspect, the physical and health aspect, and also the social aspect where you can't go to work or you might spread it at school or things like that. So that was kind of helpful.
Yeah, that was great. Thank you.
Yeah, so any other questions I can help you with? Or I know that you sent me a list and I have a lot of information here and I can go over whatever you guys want me to.
Yeah,
Feel free to type a question or anything.
I think I wanted to see if anyone else had any questions, because I know, like for me, I'm sitting here taking notes about all this information and things always pop up in my brain. But I want to give other people, if anyone else has a question they want to ask right now. We're also going to have time at the end to ask questions, so it's totally fine.
All right, so we got a question here in the chat. Looks like, so does the Moderna vaccine have a booster? So great question. I know that everybody that has been vaccinated or is kind of still contemplating getting their first 2 doses are wondering like boosters. So for the Moderna vaccine at this time, there isn't an actual booster. What I know so far is that data is currently being submitted to the FDA for booster approval. And the reason why there isn't a booster for Moderna yet is because if you remember back in December and last year, Pfizer was the first company to put out data and Moderna was a couple months behind. So if you think about it, everything that happens with Pfizer, it's about a few months behind with Moderna. And actually, what we're seeing with Moderna is because it was a higher dose vaccine, and it was also given within 4 weeks instead of 3 weeks, people's immune systems might actually be a little bit better. And therefore, a booster might not be needed until maybe 8 months out or even 12 months out. But once we get more data on that and what's published, we'll really know when a booster from Moderna people, or what people who got Moderna will be needed. So I hope that's helpful. What are current staffing levels in your unit? Is there a concern for lack of resources currently for staffing? Okay, so that's a good question. So in the summer when we had kind of a little surge, it was pretty hectic. Luckily in my ICU, we stayed at, about 1-to-1 or 2 patients to 1 nurse. But we also had to add extra help from our charge nurses who usually take care of the entire unit. But in our case, a lot of our charge nurses also took on patients because we were so busy. So as far as resources and masks and PPEs at my hospital, we are okay on that aspect. What is really impacting though, or what is really impactful from COVID that not a lot of people talk about is the medication shortages, excuse me. But what I'm seeing from the pharmacist point of view is a lot of our ICU medications, our drips to keep people sedated, our remdesivir, our tocilizumab, which is another treatment for COVID-19. All of those medications that we use for COVID-19 patients are actually on a severe shortage. So everybody in the entire country is trying to scour different wholesalers, manufacturers, just to get these drugs to get us by for the next COVID patient and also the next ICU patient. So from a resource standpoint, PPE is okay at our hospital. Staffing is decent. I feel like when we reach the fall and winter, it's going to be a little bit more hectic. I know that for me, last fall and winter, in general, I take care of about 20 to 24 patients. In the fall and winter of this past year, during the big surge, I took care of at least 30 to 35 patients. So my load was up by like 30%, which is pretty hectic when you're in the ICU by yourself. So I expect if we do have a surge, our resources will be a lot more scarce, and that includes staffing as well. I'm already fully vaccinated. Should I still get flu shots? Great question. So what I've been seeing mainly from the pediatric point of view is there's a virus called respiratory syncytial virus, RSV, which is common in adults and pediatrics, but is really only occurs in the winter. What we've seen when we took off masks in May and June is this winter virus making a big surge in our pediatric patients. And that is something that we don't really see. So the reason why I mentioned RSV is that it's a respiratory virus, kind of like the flu. And what I expect, or what a lot of us are thinking about in the healthcare field, is that the flu will probably come surging back this fall and winter because everybody's been traveling throughout the summer. And the flu is really a seasonal respiratory infection that gets traveled from different parts of the world during their winters. And so I expect this year we see more of that twindemic that people were talking about last year, only because we've opened up so much throughout the summer that the flu has probably had a chance to spread. As far as the flu shot, I highly, highly recommend anybody, if they're able to get the flu shot this year, and actually every year, to be honest. And the reason for that is you don't want to be fighting two infections at the same time and wearing out your immune system. And also having any vaccine will actually boost your immune system slightly. So for instance, if you get the flu shot, it will boost up your immune system, your innate immune system, and it will have, for instance, it will have a lot more security guards around your body for the flu season. And when you have more of these innate immune system, antibodies and signals in your body, it can also help detect COVID much faster. So for instance, I've seen patients who get flu vaccine or MMR or anything like that earlier in the year, and they actually have a little bit more protection from COVID. And there was actually a study, I think, done last year showing that those who had the flu vaccine had less severe symptoms from COVID. And that is because your innate immune system, which catches everything, is a lot more active after a vaccination. So yes, get your flu shot, and you can actually get your booster and flu shot at the same time. So I'd also tell people that as well. And that's mentioned by the CDC and the ACIP as well. Oh, there's another question. Okay. So I heard about research showing something about the COVID-19 vaccine providing long-term immunity due to the antibodies in the lymph nodes. Is this false? So, okay, so as far as long-term immunity, this is something that is being monitored very closely. What I can say is, because the pandemic and the vaccines are still a year out, we can only go with what data we have. So as of right now, we have over maybe a year and a half worth of immunity data. And what we're seeing is if you're not immunocompromised, you are still really protected, at least 85% or more. And if you are immunocompromised or elderly, that protection kind of goes down to the 70s, but that's why we're giving a booster. And with that conversation, we don't really know the exact regimen for the COVID-19 vaccines yet. So having this third dose might prolong immunity much longer. So yeah, as far as long-term immunity, we're still gathering that data, but overall the efficacy hasn't really changed. It's been between the 80s and up for most people. And if you're immunocompromised, it's a little bit less, but that's why you get the booster. Does that kind of answer your question? So it's not necessarily false, but as we get more data, we'll know more. The first question I got was, are the vaccines microchipped? And I think a lot of people would laugh at this question, but this is a really popular question that people who aren't very familiar with vaccines or what's in it ask. So the short story of it is, obviously there's no microchips in the vaccine. And I think that the idea of microchips being in the vaccine comes from the fact that Bill Gates did some of the funding for the vaccines, and also one of the specific ingredients in the vaccines is called a lipid nanoparticle. So when people think of nano, a lot of the times, maybe they think about nanobots, but actually that's not the case. Lipid nanoparticle means it's a very small fat particle, and what that does is surrounds the genetic material. So what actually is in the vaccine can be broken down into really 3 ingredients, and you guys all probably know it because you had the handout. You have the genetic material, which is found in the mRNA vaccines, or the adenovirus vector, which is the J&J vaccine. You have the fats and lipids, so the cholesterol, the phosphocholines, the pegylated lipids, or PEG, or polyethylene glycol, which surrounds the genetic material, kind of like a submarine or a wetsuit, so that way the genetic material doesn't get eaten up by your body. And then you have the salts and stabilizers. So these salts and stabilizers, such as potassium chloride, sodium chloride, which is table salt. You have acetic acid, which is vinegar. You have sucrose, which is sugar, and ethanol, which helps make everything stay soluble and not clump up. All of those things help keep the vaccine happy, so that way when it enters your body, it also matches your body's pH and doesn't make your body angry in a way when it's injected into your body. But there is no any metal compounds. There's no thimerosal, which is something people always are concerned about with the flu vaccine and mercury. There's no metals. I believe they are latex free, and that could depend on which needle and sort of syringe people use. But I brought a little show and tell for you guys. Here is the needle we use. It's a 25 gauge. It's the smallest needle we have. And basically, the smallest microchips we have cannot fit into this. You need a needle like 10 times bigger, like a 16 gauge or something like that. So super small. We use the smallest needle, and you can't even feel it when you get injected. And it's really only 1 second of injection if someone does feel the pain. And another thing is, if microchips were actually in the vaccine, this is how the vaccine comes in vials of little genetic material, and we dilute it in water. So it'd be almost impossible to get every person who got the dose. So that about 5 doses can be pulled out from this. It'd be impossible to give all 5 people a microchip, so at random. And that's really how the vaccines are drawn up. They're mixed in these vials, diluted, and then drawn up with the really small syringe that wouldn't really be able to hold a microchip. So how long should someone wait to restart their COVID vaccines from a different vaccine manufacturer? So I think my first question to this is, I'm curious for the reason why someone would want to switch manufacturers if they already got one of the vaccines. So if it was J&J, it would be a single dose, so that's obviously out of it. But I guess maybe if someone got Pfizer in the first dose and then switched to Moderna for their second dose, I'm not quite sure. So if someone did ask that question, feel free to clarify it in the chat. But my recommendation and the recommendation from the CDC is to get the same vaccine you got from the first dose, only because that's what's been studied. And also, it's the best way to stay compliant with the vaccines is to get it where you got it. Unless you got it somewhere that's currently closed, then you could probably look for the same vaccine at a local Walgreens or CVS. And what I've heard with mixing vaccines, because I feel like that data is almost ready to be published, but not yet, is that there's no real risk to mixing the vaccines, but because there's no data, it's not something I would personally recommend. Oh, okay. That was another thing I was thinking about, Sinovac. So Sinovac is I believe it's a Chinese vaccine. So in that case, it's a little bit different of a mechanism. But anyways, I would urge that person, if they are going from the Sinovac to Pfizer, Moderna, that the sooner the better, as long as it's been maybe 3 to 4 weeks. But I'm not too familiar with the Sinovac in general, and there isn't really much data on mixing Sinovac with Pfizer and Moderna. But if they really wanted to restart it, I wouldn't delay therapy, and they can get it as soon as they're available to get it. So I've also heard of some people looking to get the booster soon that originally got Moderna and asking if they can get the Pfizer booster. Okay, so with that, I wouldn't necessarily recommend getting the Pfizer booster early if you got Moderna, only because we don't know the data on getting a booster after Moderna. Because Moderna is a higher dose and same mechanism, higher dose, we actually found that those people had a stronger immune response anyways. So getting a booster wouldn't really be helpful, even if you qualified for the Pfizer booster at this time. I would honestly wait until more data comes out, because if you get the Pfizer booster, that's one dose that you're taking away from someone who could get their first Pfizer dose or second Pfizer dose, or someone who's immunocompromised and really needs the booster. So you'd be taking away a dose from one of those 3 people. And it's not really well studied to mix the vaccines anyway. Okay, number 3 here, pregnancy and COVID vaccine. So yes, pregnancy is one of those topics that's a big hurdle to get that population vaccinated, because obviously, pregnancy is very important. You don't want to mess with anything with the reproductive organs or the fetus, or if you're someone who was very desperate or had like in vitro, you don't want to mess up the entire process. But the data actually shows that vaccines are extremely safe in pregnant women and also in breastfeeding women and their babies. So a recent study done through vSafe, which is a program sponsored by the CDC, where they look at people who got the vaccine and track them through the app, and you could sign up voluntarily. They looked at about 5,000 pregnant patients in the first, second, and third trimester. And what they found is the amount of babies who were born premature, who had sustained the neonatal ICU, who had low birth weight or death were all the same as a normal population pre-COVID. So what that says is the vaccines do not affect pregnant women or the developmental process. They also looked at the fetuses, they have any defects at birth, and all of the defects that did happen, which I believe was about 42 defects were observed, all of those coincided with what they saw pre-COVID. So that means that the vaccines do not cause any defects that we know of, and they do not cause prematurity in babies or underdevelopmental conditions. What I will say about pregnancy and vaccines is that those who are unvaccinated and pregnant and end up getting COVID anytime during the first, second, or third trimester are at a higher risk of preterm delivery, more complications in the fetus, and also a very, very high risk of dying from COVID. So you might have heard from other states that those who are pregnant and had COVID-19, they never got a chance to hold their baby because they had to go to the ICU after premature delivery, or they're stuck in the ICU and can't hold their baby because for obvious reasons. So when you are pregnant and get COVID-19, you end up being in the immunocompromised group. So which means you're at a higher risk of getting severe infection. Also, one benefit, if you do have someone who is concerned about pregnancy and breastfeeding, according to ACOG, which is the American College of Obstetrics and Gynecology, recommends getting the vaccine because one, it protects a pregnant patient from dying from COVID and getting severe infection. Two, it helps with fetal development. And three, which is the most important thing, or which is the most interesting thing to me, is that when people are breastfeeding their fetuses, the antibodies made by the mother actually transfer to the baby by drinking their breast milk. So what that means is that the baby's mouth, their esophagus, their respiratory tract, all of that is covered in COVID antibodies, which means there's extra protection in case COVID does somehow fly into the baby's mouth. The antibodies can actually deactivate the COVID before it causes any symptoms in the baby. So you're actually doing a service to your baby if you do get vaccinated because they've shown positives when you breastfeed. And if someone asks about breastfeeding after the COVID vaccine, you don't need to what they call pump and dump. So they would pump their breast milk after a certain time and then feed their baby the remaining breast milk. You don't need to do that because, again, there's important antibodies for COVID-19 in the breast milk that you don't want to waste and protect your baby with. As far as pregnancy and COVID-19, extremely safe. And all the data that we have so far from every study, phase 1, phase 2, phase 3, the vSafe data, and also some of my anecdotal data from looking at patients in the pediatric units and my coworkers who have been vaccinated, it's all extremely safe and does not cause infertility or anything like that. All right, number 4, how come the vaccine was approved in a small window of time? So this is another extremely common question because people are worried, when's the last time a vaccine has been discovered and researched was years ago. And that technology took a really long time because our computers weren't as fast and there wasn't as much spreading of data and things like that. So the reason why these COVID-19 vaccines ended up being delivered really, really fast has to do with 3 of the main barriers that happen with any vaccine or medication research. So the first one is a lack of participants. So what happens in normal trials, it's really hard to get participants to take something that's extremely experimental. And in this case, with the Pfizer, Moderna, and J&J vaccines, we had a lot of participants who were scared of COVID or were really concerned about COVID and decided to get into these trials. So we had, about 40,000 people in the Pfizer, about I think 30,000 people in the Moderna, and I think 30,000 people in the J&J, something like that. But we had all of these volunteers sign up for the phase 1, phase 2, and phase 3 trials. And that is one of the barriers that was overcome quickly. Another barrier that sped everything up was the funding. So all of the countries that were able to fund these vaccine trials paid ahead of time, if you will. And that made it so that the researchers would not be worried about funding as far as making sure that the staffing and the data collection, all of that was smooth. And that's not done in every trial. So having the funding ahead of time and making sure that, hey, if this works, cool. If it doesn't work, it's okay. We just want to get your research out there. That barrier was overcome through a lot of funding and manufacturing. So manufacturing is something that takes the longest time because after you do the trials, you want to make sure it's all safe and the FDA does the approval process for that. And in this case, they started doing the manufacturing even before the trials were done. And that was overseen by the FDA. And what they told the companies was that, hey, we'll wait for your trial data to happen. But in the meantime, let's make all these vaccines so that way, the second we see that the data is good, we'll send out these vaccines extremely fast. So there's no delay. So those were the three main reasons why the vaccines were approved in a small window. Some other things is that if you think about any group project you've ever done, the more the merrier, and the more people working on the problem, you can solve it faster, right? So all of these studies were done around the world. For the Pfizer specifically, 153 sites in over many countries, including US, Argentina, Germany, and others in Europe, I believe. And so having this team of people working on this vaccine and sharing data in real time, kind of like a Zoom call or a chat or a Google Doc, essentially, around the world, really sped up the research and getting all of this data in. And then one thing I also wanted to mention, and now it's escaping my mind. Oh yes, so with the mRNA vaccines, another reason why they were so fast to develop is because a lot of the hard work and research has been done for many years. So a little history lesson with mRNA vaccines, they were actually discovered in the 1980s. So that's about 40 years worth of research for mRNA vaccines alone. You also had research about mRNA in general since the 1960s and the lipid nanoparticles since the 1970s. So really, we've been studying this mRNA technology for almost like 60 years in most cases. So really the hard work about discovering this technology was done already. It's just we finally had an opportunity to use this technology on something that could help people. And that's really other things that sped up the process. Just to summarize it, we were a lot more efficient, there was a lot more funding, and everybody was communicating. It was essentially basically what it was. And that really made the whole process much faster. Okay, now I'm gonna switch gears to this question really quick. And again, if you miss anything, don't be sorry. This is good, this is exciting. Okay, are the teens, young adults that have contracted COVID at music events due to them being unvaccinated? Yeah, so there's a couple things. As we all know, if you're fully vaccinated, you can still technically get infected and spread it to others, but the time of spreading is a lot lower. And if you're asymptomatic, usually you won't be able to spread COVID-19 as well as those who are symptomatic. In most of these people, or in all the people that I've seen, again, in the ICU, they're all unvaccinated. So the national average is about 98% of people are unvaccinated, hospitalized. In my ICU personally, 100% of people are unvaccinated. And if you look at the floors, it's about maybe 99% are unvaccinated people. And again, those are people who caught it from either gatherings, visiting, doing high risk activities, and things like that. So yes, unvaccinated is really what we're seeing in the hospitals. So the fifth question I have is who can get the booster shots right now? So if you've been keeping track of the CDC and the ACIP, there was a lot of back and forth over the last couple of weeks about who should get it, should healthcare workers get it, should pregnant people get it? And the final decision is this. So those that are 65 and older should get it. Well, I guess the first criteria, well, let me back up. You have to have the full Pfizer regimen after 6 months, then you're eligible for the booster dose. So those that are 65 and older, those who are 18 and older who are in a long-term care facility, so a skilled nursing facility, an LTAC or a long-term acute care facility, so someone who might have had a trauma or might have a prolonged illness where they need to be taken care of at a facility. Those 18 and older who work in a high-risk environment or occupation, so healthcare workers, correctional officers, teachers, educational staff, grocery store workers, people who come in contact or close contact with other people. And then the last group of people would be 18 and older who live in a high-risk situation. So again, this is like the long-term care facilities and potentially, and I'm not quite sure, I tried to look at the data today again, but maybe correctional facility, people who are prisoners or who live in a correctional facility may also be on that list, but I'm not quite sure about that. So the four main categories: high-risk individuals, so 65 and older, 18 and older who are immunocompromised, have diseases, or are at a long-term care facility, 18 and older who are at high risk of occupational exposure, and then 18 and older who live in a high-risk setting, like a correctional facility. Okay, can you get a different booster than your original shot? And I think I mentioned that earlier. It's not really recommended. I would wait till the data comes out because it's coming out hopefully by the end of the year from Moderna and J&J. And I believe everybody may or may not get a booster dose. It just depends on when the data comes out and what is seen with the efficacy. And then if you are someone who did get J&J, the booster dose is supposed to boost your immunity or protection up to like 100%. So that's really cool. And we'll see more data when that comes out. Nice. There's a link there from Amy about those eligible for boosters. That's great. Okay, what other questions do I have from you? Okay, so another question I had here was, how come only Pfizer is FDA approved? So this really has to do with the process for getting any drug FDA approved. So if you're not really familiar, I'll just run through how this works. So there's for EUA, emergency use authorization, anything that gets that designation has the same criteria to become FDA approved. So that is, animal studies, phase 1, phase 2, and phase 3 studies, manufacturing studies that are up to the standards of the FDA, which is pretty much the highest governing body for any standards in the world, and at least 2 months of good safety and efficacy data. And that's from the phase 3 trial. So to think about that another way, you have to have 2 months of data from the phase 3 trial in order to be accepted as an emergency use authorization. The difference is that for FDA approval, you have the same thing: animal studies, human phase 1, 2, and 3 data, manufacturing, and then at least 4 months of data from the phase 3 trials. And then they continue to monitor it after that in case they need to pull the FDA approval. But so with that being said, the Pfizer is the only one with all of that data that again, remember, they submitted their data first, and then Moderna was a few months after that. So that's the reason why that Moderna and Pfizer are still a little delayed. It's being reviewed probably at this time. Let's see, what are the long-term effects of the COVID-19 vaccine? Okay, so this is another question that I feel is asked a lot, and there's not a lot of great answers unless you're someone who's really familiar with vaccines. So in general, in the grand scheme of things, the world has eyeballs on all of the vaccines, right? We still don't have all the data on long-term effects because vaccines have only been around for like a year. But we do have a lot of history and studies from every other vaccine in the entire world. And what we know is that if a vaccine has a long-term effect, the long-term effect will be present within 6 months within 6 weeks after a vaccine is given. So as you heard earlier with the EUA, the FDA requires 2 months of safety data. That is because they're looking at these long-term effects within that 8-week period. And then in general, with any long-term effects for any vaccine, they would be present within 6 weeks. So some examples from history were polio vaccine. Anybody that got the rare polio infection from the vaccine, it occurred within 4 to 6 weeks. 1976 swine flu, GBS, Guillain-Barré syndrome was seen within 6 to 8 weeks of that vaccine, and then rotavirus, rare intussusception was found for the rotavirus vaccine within 8 weeks. So if it doesn't happen within 8 weeks, it is safe to say that as of right now, there's no long-term effects that we know of, and it's still safe to give the vaccine. And again, the whole world is looking at this data, and with over billions of doses being given, if there was any crazy situation, such as things I've heard, spike proteins accumulating in the reproductive organs or causing clots everywhere in the body, if it was seen, the world would address it, healthcare workers would address it. Me in the ICU, where I work in a high vaccinated community, would see these patients coming in, dropping like flies into the hospital, and we're not seeing that. So that's another reason to support that. We don't see any of these crazy long-term effects, and we don't expect it because these vaccines live in our bodies for an extremely short period of time. So mRNA only lasts about, I want to say, 72 hours, and then it's broken down because it's so fragile. And the spike proteins usually last, again, another 48 hours to weeks, depending on your immune system. And that is because your immune system learns how to eat this spike protein, and then it gobbles up all the spike protein in your body. And then you don't have any more side effects from the vaccine. So yeah, as far as long-term effects, one thing you can say out in the field is that this is being watched very closely. And based on historical data from the CDC, there has not, based on the CDC, there hasn't been any data to show that there are any long-term effects expected, because if there was a long-term effect, it would have happened within the studies in 2 months, and we're not seeing that. That's all the questions I had so far, but I can keep going. I can talk about whatever you want, and I can also revisit some of the topics I just talked about, because I get a little excited and I talk a little fast about these scientific things, but hope that was helpful.
This has been super helpful. I feel like in like less than an hour's time, we've gotten enough information where we would have had to search for 15 to 20 different articles and then cross-check to make sure that information was correct. And
yeah,
so nice to just have it summarized like this.
In general, if you or your canvassers have questions, I'm just going to extend an invitation again. Feel free to, you have my email, probably traumasysrx@gmail.com. You can message me on Instagram. You could comment on my videos, and I can do more stuff like that. I can do more videos specifically for you guys, because really my job as a healthcare professional is to advocate for my patients and the public health. And by doing that, I have to do my research and use my own expertise. So there's a lot that I know about COVID that I can pass on to you and to the community. So please don't be shy and message me whenever. And I can take a lot more questions now. I prepared a lot more things in case you guys had questions, and if we have any other future talks, we can always do it topic by topic as well. And I know somebody mentioned something about ivermectin. So I don't know if you had any questions about that, or vitamin D, vitamin C, or any treatments or anything COVID related, let me know. Yeah, so ivermectin is one of those things that a lot of people still keep fighting to get in the hospital, and it doesn't work. So from anecdotal evidence, or let me take it back. So the scientific evidence is there's no data. CDC, NIH, and the WHO do not have any data to suggest it works. And there are trials done in Oxford, England, that are random controlled placebo trials. So these would be legit trials. And so far, it's not really expected to show anything except for the ivermectin doesn't work for COVID. Ivermectin is used in humans. It's safe at specific doses, but again, you don't want to use it if you don't have a parasite infection, because that's the only thing it's studied for and effective for. As far as what I've seen in the hospital, back in March of last year, when we had our first patients and didn't know what the heck to do, we did give patients compassionate use for ivermectin. So patients who were on the ventilator for very long periods of time, we would give them hydroxychloroquine. We gave them pretty much everything but the kitchen sink. And what we found is none of them really worked. And then the only thing that really works is Decadron, which is a steroid, which helps stop the inflammation. And also remdesivir, but that's kind of like 50-50 now that we have more information. And also Regeneron and other monoclonal antibodies we use. So the consensus right now is you should not use ivermectin, even if it's for prophylactic or preventative reasons, because you have these unwanted side effects and it can cause, nausea, GI tract issues, seizures, all these things that you don't need to do. And instead you can get something that's extremely well studied and safe, and that's a vaccine. And it's a one-time thing and a short period of symptoms, and it's much safer. Yeah, no problem. Yeah, ivermectin is one of those things that people keep bringing up. And as a pharmacist and someone who we've actually used it on COVID patients for compassionate use, it doesn't work. It's really, you're just adding something an unnecessary poison to the body. And when you practice medicine, or at least when I practice medicine, I usually take the less is more approach, which is, optimize medications, only do what is studied, and help the patients out, advocate for the patients in that aspect. So if anybody asks you about ivermectin, you can always say that NIH, WHO, and all the big governing bodies who have studied this extensively have not seen any real data. And anything would be harming the person. Yeah. Any other questions? You have me for another 20 minutes or longer, however you want. This is fun.
Where, without listing off 20 different places, where would you recommend that people try and get information to stay updated? Like what websites or news sources?
Right. So the best place to get information is cdc.gov, and I would say that a lot of people that are hesitant are kind of mistrusting the government. So if they don't trust that, really, Mayo Clinic is another one. If they really want to go to like WebMD, there's some decent, easy to understand information. And yeah, I think that those are the best sites. If they don't, I'd also say NIH is also another good one. And there's a lot of cool graphics nowadays with Googling anything with the vaccines. There's a lot of cool graphics that show what it is that's happening. But I would say, yeah, those three are pretty good, or those four are pretty good sites to start off with. And all the graphics and things get a lot easier. I'd say if they don't want to go search for that, follow the CDC Instagram and NIH Instagram. They always have daily graphics and super easy to understand. So those are the top four, I would say, for basic learners who want to learn more. And I would say the best one also would be to just talk to their doctor. Say like, this is really what's going on, but I really urge you to talk to your doctor if you have one, or even talk to your local pharmacist. I know that when I was in Stockton working at the Fremont Street Walgreens, a lot of patients could not afford healthcare. So they went to the pharmacist there, and a lot of time it was me as a pharmacy intern giving out advice and free information. So pharmacists are always great options. And if they don't want to go to their doctor, they can always ask their pharmacist. I have a question. Have any of you canvassers, when you're talking to patient or when you're talking to people out there, have they ever argued about like natural immunity versus like vaccine immunity? Yeah. So that's another big thing, along with the ivermectin sort of group of people. Yeah, so, okay. There's a lot of resistance to get the vaccine because of what's said about natural immunity being better because of the Israeli trial that happened a few months ago. So from a healthcare perspective and from a scientific perspective, natural immunity does exist, and the Israeli study did prove that. However, no good healthcare provider would recommend going out and having a COVID party or purposefully getting infected with COVID, because there are a lot of short-term and long-term risks of getting COVID infection in general, right? and if you're not unvaccinated. So you can get severe infection, you can have long COVID, you can have clots, respiratory issues, and all the things we already talked about. And that is the risk versus benefit. So you risk doing a natural infection and getting all these symptoms and going to the hospital and possibly dying, or you get a really well-studied vaccine that's made by the scientists who actually took it, and there's only some short-term side effects, really good safety data, and you're protected from dying from COVID. And yeah, that's what I would say is there's a much more higher risk of complications of getting the natural infection versus getting the vaccine. And it's extremely safe. And every eyeball is on the vaccine. And it's made by people who got the vaccine themselves and advocated it for their friends and family anyways. So they have what we would call skin in the game. So if they'd made something horrible, it would affect not only everybody around the world, but them and their families. He also said that having natural immunity is comparable to getting vaccinated. So because he has already contracted it, he didn't need to get vaccinated. So that's another argument with natural immunity and vaccination. Here's the thing. So in the initial studies, natural immunity and vaccine immunity does have similar protection, but it's variable. And what I mean by that is if you're someone who's young and healthy and got COVID last year from the Alpha variant or something, and you had mild symptoms, you might only have like the antibody protection. But what makes the vaccines really superior is the adaptive immunity portion. So having the B cells and T cells and basically strengthening your immune army. That's what the vaccines do. If you're someone with a severe infection, maybe your immune system's better, but you have it at the cost of having damaged lungs. Maybe you had a clot while you had COVID-19, so you're at risk of stroking in the future. Maybe you're on additional medications such as an anticoagulant, or now you have to take inhalers or anything after the COVID infection. Maybe you had a long-term stay in the ICU, so now you have brain fog and neurological issues that you need to work through over months. So yes, natural immunity does happen, but again, it comes with all of these risks, even though someone who just so happens to get infected may have similar immunity. We don't know how great that immunity will be long-term. So getting the vaccines ensures you that you have really good adaptive immunity at the lowest risk possible of dying. So I hope that helps. I know there's a lot of argument about, if you've had previous infection, you do have immunity, which is true, but you're much better off at preventing reinfection for yourself, especially if you did have damage from COVID-19 infection, of getting a vaccine. So that way your immune system is what they call, or I don't know if you follow any other YouTubers, they call like uber protection. So your antibodies are through the roof, your immune system is as strong as it can be against COVID. So that's what I would say. If you got previously infected, the recommendation and the studies from the Israel study, that same study, show that previous infection and at least one dose of the vaccine give you the best protection possible from COVID. And if you're someone who got COVID before, mild symptoms or not, that COVID is in your body and does damage. So I would keep that in mind. Like it's not a zero risk situation to get COVID. Versus if you get the vaccine, yes, there's a little bit of risk, but it's way lower than getting the COVID infection. And we know what protection the vaccines have. So it's still like kind of gambling away your safety if you do get previous infection and no vaccines. What are the current estimates for how long the post-COVID antibodies protect you? Are you talking about like from previous infection or?
Like me, for example, I'm fully vaccinated, but I've also gotten COVID, and a lot of people are like, oh, well, you're good now for, however many months. You don't have to worry about it or be safe.
Right.
Which is not what I'm doing, but
yeah, so what I've seen so this is data that was extrapolated from last year, from the 2020 people who got infected, but we're seeing antibodies last as long as 8 months, and compiling that data together with the original SARS-CoV-1 virus, I guess, from the 2000s or 1990s, the antibodies lasted at least 3 years. So as more data comes out, maybe the antibodies will last longer, but it all depends on the type of infection you had, to be honest. I would say what we have right now, about like 8 months protection. But again, getting a vaccine dose makes that protection a lot better, because again, in the hospital, we're seeing 98% unvaccinated. That includes people who previously got infected with COVID or thought they got infected with COVID. So reinfection is still real. Just as breakthrough infection is still real, but there's way less breakthrough infection compared to reinfection with COVID with an unvaccinated patient.
I think there was one more question before mine. For people who are trying to avoid going to the hospital after contracting COVID-19, what is a sign that they should go in?
Okay, so this is an interesting question. You have to follow your symptoms. So the second you know you're positive for COVID, that kind of starts your day one of kind of like looking at your symptoms. I would say if you have a chance, get one of these pulse oximeters, and you can monitor your oxygen. If it falls below maybe 93, I'd go to the hospital. But I would say don't delay therapy. If you don't get better within 1 or 2 days, I would say just go straight to the hospital anyways, because it's better to be looked at by a healthcare professional who can monitor your symptoms and also look at your x-ray just to see how bad the COVID is. Because with COVID infection, we have a lot of great treatments such as Regeneron, monoclonal antibodies that work only if you're within a very short period of time. So within 7 to 10 days of getting infected, that's the only time you're eligible to get the Regeneron, and that will make your infection much shorter. So I wouldn't delay therapy. I would say wait maybe a day if you really want to, a couple days if you take your Mucinex or Tylenol or Dayquil. See if that helps. If you don't feel better, I would at least go to urgent care or go to the hospital, because we have monoclonal antibodies that can help you get through your course faster. Yeah, so with that pulse oximeter thing, if you do get it and you're not COVID positive, check your baseline. That's what I always tell people. Check your baseline, see if it'd probably be 98 and up. And then check it while you have COVID. If it drops below 93, 94 consistently and you're gasping for air, I would definitely seek further healthcare attention at that point. And then, like I mentioned, I had that patient who was 24 years old, spent 12 days at home with COVID, thought they were getting better, but were sitting on the couch, laying down all day, and they ended up getting a clot. So making sure you're kind of just looking at how you feel when you're normal versus how you feel when you're sick, and those sorts of situations. And if you check out my Instagram and you are someone who got infected, I do have some tips on how to test or when you should test based on the CDC guidelines. And I also have some tips if you want to take care of yourself at home. So if you have a mild infection, and also when to seek more medical attention. So I have some tips on there if you want to check it out.
All right, I'm pulling up the link to your YouTube channel. I can put it on here for folks.
Yeah, I've been a little busy in the ICU lately, so there'll definitely be a lot more content coming out in the next few weeks. So look out for that if you're interested. And I'll probably be taking a lot of these questions and trying to snip up some short videos so that way you can either share with your friends and family. And yeah, like and subscribe if you're interested, or share it with those who might be looking for another voice that's not a physician or maybe someone who's advocating for easy to understand healthcare. So yeah, and then on my Instagram, I try to put similar information to my videos, but also information that's maybe need to know, such as the boosters, a lot faster through there. So you can always share those as well. And yeah, a lot of new content will be coming out soon. So especially with all the questions I've been getting. So feel free to check that out if you want. And also, that's the easiest way to get in contact if you guys do have questions while you're canvassing. You can always send me a message or an email, and I can help you right away. I do like what you guys are doing, though, because not a lot of people, I guess, are brave enough to go door to door and ask people about this very touchy subject that's polarized in the communities. Because I do read a lot of the Stockton Instagrams and comments, and I see a lot of anti-vaccine notions. And for you guys to canvas and talk to people one-on-one, face-to-face is really good. So think you guys are doing a really great job. Just keep it up. Because whatever you guys do now will definitely help with the winter surge. And I think that's the scary thing that I'm personally scared about. I don't want to go through another surge like we did this winter, and that's why I'm trying to push everybody as nicely and educationally as possible to get vaccinated.
All right. Well, I think we will let Freddie's throat take a little bit of a break. Thank you so much. This has
anytime. Yeah.
This has been awesome. And I'm hoping we'll be able to work with Freddie again for some future events where we're continuing to talk about this, because as I said at the beginning, it just keeps on changing. And it's so hard to keep up with all of this information. So thank you for being here and sharing. You have an abundance of knowledge like at your fingertips. And so it's wonderful to have you essentially like on speed dial, that you
be anytime, really.
So thank you. Yeah, if anyone is interested in learning more about this, like, please subscribe to Freddie's YouTube channel. Jenny is asking in the chat if this recording will be emailed to folks. Yes, I can send you all the link. I'm also going to send out to everyone just a really brief survey to see what you thought of this event, if you learned anything, and Freddie, I'll share all those results with you as well. But yes, I will make sure that you guys have access to this, and I think we're likely going to try to post it up on Facebook and Instagram too, so that you can share it widely with other people. So thanks everyone for being here today. Yeah, looking forward to more continued conversations and safe conversations and events around COVID and vaccines. Thank you to the canvassers who were here contributing. Thank you to everyone for contributing questions, and especially thank you to Freddie.
Thank you guys so much. I hope this was really helpful for you. And again, I'm here as a resource. I know it's hard to find information, so anytime, feel free. Don't be shy. And I look forward to more conversations with you all.